Hey there, this is a video for nurses and nursing students where we talk about fluid status, hyper and hypovolemia, as well as edema. So without further ado, here is deficient fluid status, and if you have any questions, feel free to leave it in the comments, and we look forward to answering them for you.
So in this video, we're going to be talking about fluid status, both excessive and deficient fluid status. We're going to start with deficient fluid status, which just means not enough fluid in the body, right? So this is going to be increased risk for anyone who has issues with swallowing or weakness or anything like that. So highest risk for patients with difficulty swallowing, which is known as dysphagia. Anyone who has any weakness or disorientation. Most confused patients are not going to be focused on intake of fluids and may not even be safe, so that's something you're going to want to evaluate. Any levels, high levels of loss, so high levels of fluid loss, such as vomiting, diarrhea, diuresis, which could be caused by the medications that we're giving them causing too much urine output, or diaphoresis. This can also occur with massive bleeding as well. All those things are going to cause fluid to leave the body, right? So those are the most common causes that we see of deficient fluid status. So when this actually does happen, you can think about it. You have your cell here, has a couple particles in it. Outside this cell is now extremely dehydrated, so the particle concentration increases. What that's going to do is cause fluids to leave the cell to try and equalize that pressure, that gradient between the fluid status on both sides of that semi-permeable membrane, which then can lead to cellular dehydration. The treatments for this are simple. We're just going to try to increase the fluid intake, whether that's IV, PO, or feeding tube fluids. And at the same time, you're going to want to focus on decreasing whatever the cause is. So if they have diarrhea or vomiting, you're going to want to stop that. If they have diuresis, extreme diuresis, maybe consider decreasing their diuretic medication, stuff like that. What signs and symptoms are you going to look for? Signs and symptoms. Big one test is going to be turgor, so that's skin elasticity. And basically what you're going to do to test that is pinch the skin above the abdomen, forearm, clavicle, or thigh, and if it stays tented, so which means elevated for several seconds, then basically you can take that as a positive test that they have a deficient fluid status. This is not going to be helpful, not helpful for older adults. And that's because there's just natural changes to our skin elasticity, which causes tenting to potentially occur even with a normal fluid status. And then remember that with older adults, they're going to have a lower total body water percentage, and it is possible that they will have continence issues, which will cause them to want to decrease their PO intake and hopefully try and prevent that continence, but then that causes even worse fluid status for the patient. And in this older adult, you can remember that thirst is a late sign of a decreased fluid status for older adults. And for infants, you're going to, turgor also is not going to be very helpful, and infants, you're going to just check their fontanelles. And if they have a sunken fontanelle, which basically means the gap between their bones in their skull, then that can be a sign of deficient fluid status for them. Other things that you're going to look at is thirst. Like I mentioned, that's not going to be a great sign for older adults who that's going to be a late sign for. Weight loss. Dizziness and postural hypotension. Typically, the dizziness is caused by postural hypotension. And what is postural hypotension? That's just a fancy word for decreases in blood pressure as the posture changes, right? So you're going to check their blood pressure sitting, typically lying first, and then sitting and standing. And if they have a greater than 20 millimeters of mercury drop in their systolic blood pressure and a greater than 10 beats per minute drop in heart rate, then that's going to be considered positive for postural hypotension. And that just means basically when they go from lying to standing, their blood pressure drops pretty significantly because they don't have enough fluid, and they start to feel dizzy because there's hypoperfusion to their brain. What is the urine going to look like for these patients? First off, they're going to have a decreased urine output, and it's going to be very concentrated because there's not much fluid in their body like we talked about above. So the cells are going to dehydrate, trying to get rid of that fluid to equalize the pressures between the fluid both in the cell and outside the cell. And then because there's not enough fluid, they're going to be retaining fluid. Their kidneys are going to be holding on to the water as much as they can, and then anything that they pee out is going to be very concentrated because of that. Also, when you check labs, these patients are going to have an increased hematocrit. So hematocrit just means the number of red blood cells per 100 mLs whole blood. So if they have a decreased amount of fluid in their body, then you're going to expect an increase in the number of red blood cells per that fluid. And lastly, you're going to expect these patients to have a weak, fast, and thready pulse. And this is basically because there's not enough fluid. The heart is going to try and speed up to keep a steady blood pressure. These issues of deficient fluid status are most typically caused by vomiting and diarrhea. That's what we're going to see the most, especially in the older population. For vomiting, you want to make sure you document any of the contents, if there's any blood or undigested food, and then also some of the triggers. And you're also going to want to monitor their electrolytes, especially either if they're vomiting or if they're having diarrhea. Both of them can cause hypovolemia typically. So you're going to want to monitor for that. And treatments for vomiting typically include antiemetics like Zofran, antihistamines, or anticholinergics. And then for diarrhea, that can either be caused by infection or some type of GI issue like ulcerative colitis or lactose intolerance or something like that. And for both of them, pretty much you're going to limit any PO intake and then restart with clear liquids and treat with the appropriate medication, whether that's an antiemetic or some type of medication for diarrhea such as Pepto-Bismol or kaolin and bismuth preparations to help make the stool firmer. And for both of these, you're going to want to consider electrolyte replacements as possible. So that's basically it for deficient fluids and the important things that you need to know for nursing care for deficient fluid status. So in this video, we're going to be talking about excessive fluid status. And just as it sounds, that just means too much fluid in the body. So we'll go into a couple of things here, and then we'll talk about edema, which commonly occurs with this. So excessive body water accumulates first in the extracellular compartments because that's where it enters the body. And this often occurs when intake is greater than output. So this is especially high risk in patients with renal failure because they have a decreased output. Their kidney function isn't as good and they're not able to make as much urine, and therefore even with a minimal intake it's possible for them to have excessive fluid output, which means that's why they're at high risk for having excessive fluid status. A lot of times you'll hear of hypervolemia when you're talking about excessive fluid status, and that just means too much blood volume, and basically that can lead to an increase in blood pressure. Um, you can think about that as the tank is just more full. So all the vasculature is the tank, and when there's more fluid in there, it's just a higher pressure in that fixed tank. Often, you'll also hear about hematocrit when we're talking about excessive fluid status. If you watch the earlier half of this with deficient fluid status, then you know that when you are dry, then which is another way that people describe deficient fluid status or hypovolemic, then you may have an increase in hematocrit. In this scenario, because you have an excess fluid status, you're going to have a decreased hematocrit. And this is basically a decreased number of red blood cells per 100 mLs of whole blood. And because the whole blood is full of extra volume, that will dilute out your red blood cells, and that'll give you a lower hematocrit. Typically, a normal hematocrit is anywhere from 35 to 55 normally, so expect this to be lower than your patient's baseline if they have a high volume status. The next thing we're going to get into is edema, because that often occurs with excessive fluid statuses, and there's a couple different things that we need to talk about here. So first off, what is edema? And that is just an accumulation of excessive fluid outside of the cells, typically in the interstitial space, and it consists of sodium, chloride, and water. So accumulation of NaCl and H2O in the interstitial space, basically. This can be characterized as either generalized, or local. And just as that sounds, generalized is going to be all throughout the body, whereas local is just in a specific area. There are 4 general causes of edema, and we'll go through some of those here. So the first one is an increase in capillary hydrostatic pressure. So that's a lot of fancy words, and what does that really mean? Basically, it just means an increase in the pressure that's pushing the water out of the vascular space and into the interstitial space. And that pressure just is what causes the fluid to leak out, and you'll often see this as the cause of pulmonary edema, you'll hear. So pulmonary edema just means this accumulation of fluid in the interstitial space in the lungs, and we'll get into different videos about how that will really impact the pulmonary system and can impact other organs and stuff like that. But for now, all you need to know is that edema can accumulate in the lungs, and that's known as pulmonary edema, and that's typically caused from the capillary hydrostatic pressure increase. The second cause of edema typically is a loss of plasma proteins. So when you have proteins in the plasma, they work as almost like magnets for the fluid. They pull the fluid in towards them, and then that keeps the fluid in the intravascular space. So when you have a loss of this plasma protein, that's going to lead to a decrease in the osmotic pressure in the capillary space. So that osmotic pressure is what I was just talking about. That's that attraction between the proteins and the fluid around it. So when that osmotic pressure decreases in the vascular system, it causes fluid to leak out, and that leads to edema. The third cause of edema is an obstruction of a lymphatic circulation. And you'll often see this most often status post, which means after a mastectomy procedure for cancer involving lymph system. So if you think about that as the lymph collects in your arm and in your upper thorax or your chest area, it's going to be filtered by these lymph nodes in and around your armpit or your axillary system. And when you have a mastectomy and cancer in those lymph nodes, then they will often remove those lymph nodes, and then that's when you can see lymphedema or swelling caused by accumulation of lymph, because the lymph nodes aren't able to filter that out. So this is most commonly seen status post mastectomy. This can occur in other disease processes that impact the lymphatic system, but that's probably the most common one that you'll see. And then the last cause of edema is an increase in capillary permeability. So typically, any inflammatory response is going to increase the capillary permeability, right? So that the immune system is able to get to the area of damage and provide relief. But in doing so, that increases capillary permeability and then will cause leakage of fluid as well as those inflammatory mediators, and the protein is able to leak out, and then that's going to cause pressure gradient changes that we talked about in the second cause of edema. So the increase in capillary permeability from anything like sepsis, trauma, burns, those kind of big issues that are going to cause dramatic inflammatory response. Getting back to the generalized versus localized edema, real quick, localized edema is usually non-pitting, and you're going to see that as like tight skin over a reddened area, and it's just going to be in one spot. Whereas generalized edema, you're going to be able to notice in multiple spots. You may see it in the face and the extremities, and that will commonly present potentially in issues like pulmonary edema that we talked about. So you may see more issues with multi-organ failure and issues with pulmonary and cardiac, as opposed to the local edema, which is probably going to be what we call potentially dependent. So you may see dependent edema, which is usually in the lower extremities, where you may see a patient who isn't moving around too much and they'll just start to collect fluid in their lower extremities. So now there's a couple things you need to think about with that. Is that coming from lack of movement, or is that from heart failure? And those are just going to be patient dependent. Commonly with the dependent edema, you will see pitting edema as well, and that can be on a scale of 1 to 4. So pitting edema, one is going to be the least, so it's 1 or mild, has almost no swelling, and just a slight indentation. If you were to push your thumb over a bony prominence. The second is moderate pitting edema, and that will have mild swelling, and it will have a moderate an indentation that subsides quickly. Three, grade 3 or deep pitting edema is going to have swelling, and the indentation remains for a short time, so a few seconds. And 4, or very deep pitting edema, at least they kept the names easy for us on this one. It's not like some crazy invented science word. But basically, the indentation lasts a long time. When you're actually doing these, you could see it, for very long time, much longer than you would expect. And you're going to see a lot of swelling. So this is typically going to be in your maybe your CHF patients who have been having some worsening exacerbations, you're going to see a lot of edema in their lower extremities, especially if they're not moving. So what kind of treatments are you going to have for patients with excessive fluid status? It's going to be important to monitor their eyes and nose because, as we talked about, output diminishing and even a moderate intake can lead to an excessive fluid status. You're going to consider diuretics, maybe help to clear out some of that fluid, and also a low sodium diet with you'll see C with the line over it as with fluid restriction. And then, especially if they have edema, consider compression devices. So that's about it on the excessive fluid status lecture. And if you have any questions, feel free to reach out and let us know. We look forward